Okay, thank you. Good morning to all of you. My name is Yanisa Wongbanthit, and I am a student in Master of Science program Integrative Dentistry and Spatial Patient Care, the Faculty of Dentistry, Chulalongkorn University. And today I'm pleased to present my project with the topic Cranio-oro-facial characteristics of two Thai patients with Apert syndrome. First of all, I'd like to give you a brief overview of the presentation, which composed of 5 sections, begin with introduction, followed by objective of the project, methodology, results and discussion, and finally the conclusion. Firstly, what is Apert syndrome? Apert syndrome, or AS, was introduced by Eugene Apert, the French physician, in 1906, also known as acrocephalosyndactyly type 1. The patients with AS are characterized by premature fusion of one or more scalp sutures, which mainly at coronal sutures, ocular proptosis, mid-facial hypoplasia, severe dental crowding or may have missing teeth, fusion of cervical vertebrae, which mostly happens at C5 to C6, symmetry syndactyly of hands and feet, which means fused finger and toes, and impaired cognitive and learning skills are also present in some cases. The incidence of AS is approximately 15 in a million live births, or 4% of cranial synostosis cases. A genetic cause of AS are the missense variants in the fibroblast growth factor receptor 2 genes, or FGFR2 genes. The FGFR2 is the receptor in the FGF pathway that play a major role in controlling homeostasis and proliferation of various cells. So alteration in the pathway leads to abnormal cranial valve development and skeletal disorder, resulting in elevated intracranial pressure and the brain damage. The previous study showed that two mutations, which most frequent, are altered in 252nd amino acid, about 85%, and 253rd amino acid, about 15% of AS cases. Although many AS cases have been reported, there are still limited reports about oral hygiene condition, cephalometric testing, and genetic variants in AS patients. So the objective of this project is to characterize cranio-oro-facial manifestation and identify genetic variation related to Apert syndrome in Thai patients. Okay, and this is the methodology. Methodology consists of 3 parts, including 1, patient selection and ethical consideration. 2 patients with Apert syndrome receiving treatment at the Princess Silinton Craniofacial Center at King Chulalongkorn Memorial Hospital were enrolled, and this study was approved by the Institutional Review Board, Faculty of Medicine, Chulalongkorn University. And the second part, cranio-oro-facial data. Oral examination was performed by the experienced dentist, and the data, namely Simplified Oral Hygiene Index, or OHIS, score was used to assess oral health status of the patient. The caries prevalence comprising the decay missing and filled teeth index and the decay missing filled surface index were recorded. And caries risk assessment and angle classification were evaluated. Lateral cephalogram tracing was analyzed by experienced orthodontists. And the third part is the genetic analysis. DNA was extracted from peripheral blood according to a previous study and then examined for the pathogenic variants associated with Apert syndrome by single sequencing. And next is the result of the project. Start with clinical manifestations. On the left side is the patient 1. Patient 1 was a 7-year-old girl. At the age of 9 months, the patient had complex syndactyly on both hands and feet, abnormal head contour, and cranial synostosis. Examination at 7 years old revealed hyperterolism, exorbitism, cleft palate, and mid-face hypoplasia. She had undergone multiple operations, including frontal-orbital advancement surgery at 1 year old, hand web space separation at 9 months and 3 years old, and also palatoplasty at 7 years old. About the oral dental manifestation. Patient 1 is in the mixed dentition with class 3 malocclusion and poor oral hygiene. The OHIS score was 2.67, classified as fair oral status, and the primary DMFT score was 13, and primary DMFS score was 29, indicating that the patient's primary teeth had high caries prevalence. Caries risk assessment revealed high risk of caries. And next, on the right side is the patient 2. Patient 2 was a 12 years old boy. Physical examination showed bilateral coronal synostosis, down slanting palpebral fissure, exorbitism, mid-facial hypoplasia, cleft palate, bilateral syndactyly of hands and feet, hearing loss, and obstructive sleep apnea. The patient also underwent several surgeries. He had low average intelligence. IQ score is about 81 and was required psychological support. About oral dental manifestations, patient 2 is in the mixed dentition with a class 3 malocclusion and gingival inflammation. The DMFT and DMFS score for the permanent teeth were 9 and 15 respectively, indicating high caries prevalent in the permanent teeth. The patient had a history of multiple teeth extraction due to dental decay. Patient had OHIS score of 1.33. The caries risk assessment was high. And this table shows the intraoral data of the patient 1 and patient 2. As you can see, most of the data of two patients are consistent, including cleft palate, anterior open bite, anterior closed bite, posterior closed bite, and they also have maxillary dental crowding due to maxillar hypoplasia, failure of tooth eruption, high score of caries risk assessment, and also both have class 3 malocclusion. About the lateral cephalometric measurement, in this study, we based on American Board of Orthodontics and rigorous analysis. Thai cephalometric norms were reported in the previous studies. The cephalometric analysis of patient 1 and patient 2 are displayed in the table, and in this table based on American Board of Orthodontics format. We can see S and A shows that they both have retrognatic maxilla. S and B and the angle between NPOG and Frankfurt horizontal plane show that patient 1 had orthognatic mandible, while patient 2 had slightly prognatic mandible. And the A and B and width show that they both have class 3 skeletal relationship. And in this table, based on the rigorous analysis, maxillary depth and the facial depth shows that both patients have retrognatic maxilla with orthognatic mandible. About the genetic analysis show that patient 1 had mutation changing serine to tryptophan at amino acid position 252nd in FGFR2 genes, and patient 2 had a change from choline to arginine at amino acid position 253rd. About the facial feature, as you can notice, the patient with Apert syndrome share a common facial feature, including maxillary hypoplasia, anterior open bite, procline upper incisor, and retrocline lower incisors. And here is the discussion section. In lateral cephalometric measurement, according to the result from the table, we can see that the maxilla position can be measured by SNA and the maxillary depth. And about the mandibular position, SNB and NPOG to Frankfurt horizontal data indicates that patient 1 had orthognatic mandible, while patient 2 had slightly prognatic mandible. And next is the relationship between two jaws. Class 3 maxilla-mandible sagittal relationships was measured by A and B. And width measurement also show that patient 1 and patient 2 both have dental base class 3. And it is known that AS patients have compensatory growth from premature fusion of cranial sutures, which result in abnormal cranial-base relationship, leading to sagittal maxillary position or SNA and mandibular position SNB can be positively deviate from normal range. So our study suggests that the maxillary and mandibular location of AS patients in anterior posterior aspect should analyze from a Frankfurt horizontal plane, which tend to align with a true horizontal plane and more relates to the face than the cranium. So from that reason, maxillary depth and facial depth are recommended. And according to the results of this study, both patients have retrognatic maxilla with orthognatic mandible. And from the studies, it is indicated that Apert syndrome arises as a result of increased affinity of mutant receptors for specific FGF ligand, leading to FGF signaling activation. So Apert syndrome is caused by gain of function in FGFR2. And compare with general Thai children at the same age. According to the report of 8 Thai National Oral Health Survey 2017, both patient 1 and patient 2 had higher carrier risks. And with all the physical and oral anomalies of AS patients, it is difficult for the patient or the caregiver to perform proper brushing or oral care. So alternative oral care products such as electric toothbrush or dental floss pick or Proxer brush or high fluoride toothpaste or maybe non-alcohol mouthwash are recommended to the patient with Apert and their caregivers. In conclusion, in FGFR2 genes, missense mutation can producing Apert syndrome. Patients with AS tend to have poor oral hygiene and high carrier risks. And this suggests that a multidisciplinary team comprising surgeon, pediatrician, orthodontists and pediatric dentists are essential to deliver prompt management of cranio-oro-facial anomaly of patients with Apert syndrome. And vigilant dental checkup and oral hygiene care must be implemented for the patient. And I would like to thank you, the Genomics and Precision Dentistry Research Unit, the Health System Research Institute, the Faculty of Dentistry to Chulalongkorn University for all the support. And these are all the reference. And thank you very much for your attention. Thank you.
Thank you very much, Dr. Yanisa. The Apert syndrome is quite a rare disease, and
yes, it's
very interesting data. Okay, is there any question from the audience?
Sorry, pardon, I don't listen clearly.
Sorry, because now?
Yes, please.
Is there any question from the floor? Okay, well, as you show in the photo, the patient 2, I see that the patient 2 has a more severity in all aspects than patient 1. Can from your result, can you please explain that? What is the underlying, or what is the factors that cause the more severity in patient 2 than patient 1?
Okay, let me take you to the genetic part. One of the factor that can affect the phenotype of the patient can be from the genetics, because they both are different kind of the mutation. The position of the amino acid that change can affect the phenotype that happens, including the maxilla position or the the position of the and proclination of the upper incisor and lower incisor, and also with the position of the head and cranio-facial position aspect.
I see. So the missense mutation from choline to arginine is quite have a impact on
Yes.
their characteristic, right?
Yes.
Is that the same? Is that the same characteristic in the other study in a different mutation?
Yes, because there are two, the most frequent that happen, these two two kind of mutation, and previous studies show that some position of the mutation can impact the way that the patient gonna have like symptom or every aspect that patient have. Not just the position of the cranio-facial, they are also have like the respiratory problem and the vision problem like that. So from the record, the patient too also have hearing loss that more severe than the patient one. That can relate to the previous study.
Okay, and the hearing loss is quite affect the cognitive learning of the patient.
Yes, and also the cognitive learning.
I see. Okay, and but about the oral hygiene in both patients, I'm not sure that the Apert syndrome has a more high risk to dental caries than the other children, because and you mentioned that it is due to their ability to cleaning their,
Yes.
and about the caregiver and also the caretaker. But is it different from the other disease or the other like children that have a neglect?
Actually, it's like because their jaw and their relationship is a kind of open bite, and they have to occlude. They cannot like have a physical cleaning with by chewing or something like that, because they cannot bite properly or cannot eat properly, and also it's hard to clean because of the high valve. Sometimes they have aspiration, and it's hard to clean and have to cope with. And due to the cognitive impairments, sometimes they don't allow their caregiver to help cleaning. They would like to clean themselves like that. So it's hard, and also the hand, they have fused finger, and it's hard to carry the toothbrush. So we need the separation of the finger to make it more easier to clean.
Time is up already.
Thank you very much, Dr.
Thank you. Thank you.